of ECT, electroconvulsive therapy, what it is, what it's used for, some, perhaps some misconceptions about it in the public, and to answer any questions with respect to, how it's done. So overall, what is ECT? Basically, as the name implies, it's an application of an electrical stimulus to the head to produce a convulsion, a seizure, for therapeutic purposes. So some myths in terms of modern ECT. I've kind of posted a photograph. These are photographs taken from films, portraying ECT in terms of entertainment, and it kind of posits a treatment that is, scary, that's, used almost for punishment. So I wrote some common myths down with respect to ECT that people may believe. For instance, that it can cause brain damage, that it only works for depression, that it's resolved, that it's used as primarily a last resort type of treatment, that it's painful, horrifying, and as this kind of image suggests, with this woman where she's kind of conscious, fully awake, and they're administering the electrical stimulus. That kind of depicts a way that it's not done in the modern times. Kind of going on from there, this is kind of another depiction from another well-known film, some of you may know, which in the context of this film, Jack Nicholson's character was given ECT kind of as a punishment in the absence of any kind of psychopathology. So that's what I kind of headed this as. It's given as a punishment. Some other myths that it can be given without the patient's knowledge, that it's given to kind of give people amnesia or make people forget things, that's the intent of the treatment. So going back in terms of, a brief history of ECT, first began to be used in the 1930s with a physiologist named Meduna, who hypothesized that there was some kind of biological antagonism between seizures and schizophrenia, and began experimenting, essentially inducing seizures in schizophrenic patients to mitigate the symptoms. At that time, 1934, it was induced chemically with a substance called metrazole. And these proved to be kind of inconsistent in terms of seizure induction, and it took a long time to elicit a seizure using these methods. So ultimately, it few Italian physicians, Cerletti and Bini, developed an electrical device to induce an electrical stimulus, or induce a seizure. And this was first attempted in April of 1938. And this allowed the patient to improve and ultimately be discharged from the hospital. And because this method was a lot more consistent in terms of producing a seizure, and it occurred quickly, it essentially, grew to replace, chemicals to elicit a seizure. Initially, when this was done, they did not use any type of anesthesia. So this is perhaps where the kind of modern myths are propagated from with respect to ECT. So obviously, this administering a stimulus to fully conscious patient without any type of anesthesia or any type of muscle relaxants was, unpleasant, as well as sometimes led to injuries such as bone fractures in the absence of any type of muscle relaxants to prevent that. So this, was done. This was considered to be unmodified ECT. Eventually, they started kind of using anesthesia essentially to put the individual to sleep, then give the treatment also to provide muscle relaxants to fully calm the patient, to prevent a full tonic-clonic seizure, full motor seizure from occurring muscularly. And this became known as modified ECT, and this is in fact what is done currently, this modified version. Some other kind of evolutions in terms of the technology, in terms of the stimulus. They started kind of using different placements as far as, where the stimulus was administered, experimenting with a unilateral placement, as well as experimenting with different types of current, where the old devices used sinusoidal kind of direct current. This was replaced by essentially a current that administers kind of brief pulses to minimize the side effects. And this, in 1976, was demonstrated, this kind of brief pulse device was demonstrated to be effective and became widely used at that point. So this is a picture of what a modern ECT machine looks like. This is a Mecta device, and this is kind of essentially what the device looks like. And there's attachments for monitoring of the EEGs and attachments for to provide the stimulus, as well as areas to monitor the seizure activity. So this is just a picture to kind of illustrate some of the variability in terms of the electrode placement, in terms of how the treatment is administered. There's kind of bilateral treatments which are provided on, on each side of the head. There's unilateral treatment, which is on the standard on the right side, in the right temple area, and then up towards the scalp. And then there is bifrontal, which is right over the zygomatic arch there. So this is a little more kind of in-depth, but it kind of provides some insight in terms of what the psychiatrist is looking at in terms of adjusting and modifying the treatment, which is, I think, you know, a lot of people may not realize that there's a lot of variables that can be adjusted and changed in response to, you know, how the patient is responding, if they're getting side effects, things of that nature. So this is some of the terminology and some in terms of the variables that are used to ultimately come out with a dosage. You know, just as a medication has a dosage, the treatment for the ECT has a dosage, but it's measured a little bit differently. So we have things like frequency, which is the number of electrical pulses per second. The current, which is the amount of electricity flowing per unit of time. This is expressed as amps. The pulse width, which is the time duration of each pulse of electricity. And then we have the kind of the total stimulus, which is the total time that the stimulus is being administered. And we put all that together, and that's where we kind of get the dosage, you know, what dose we're administering or we're giving to the patient. And this is expressed as millicoulombs, which is pretty much the standard as far as you know, dosing that's used today. In the past, they use things like joules, but that's the standard measurement, and that's essentially obtained by multiplying all of these different variables together. And this is an illustration of essentially what's happening when the stimulus is being administered, where there's the wavelength of current on the x-axis going left to right. That's time. So that's essentially the course of time at which the current is being administered. And then these individual kind of spikes that you see as rectangles, that is what we're referring to in terms of the pulse width. So there are many of these kind of rectangles together, which with a little rest in between. And that's what established kind of prominence in the 70s to minimize some of the side effects associated with the treatment, which proved to be effective. And some of the literature, you know, that has since been coming out is using ever shorter pulses is favorable in terms of preventing cognitive side effects as well as other side effects associated with the treatment. So it's kind of a counterpoint to the myths of ECT. These are essentially, you know, some facts regarding modern ECT. There's no evidence that ECT causes any kind of permanent neurological damage, and may in fact have kind of a promote nerve growth. ECT, as it's used today, it may be indicated if a rapid response is needed, if someone's an imminent threat to themselves and they need some fast way to stabilize the patient, ECT may be indicated. As medications have kind of a prolonged effect to start working. as it's administered today, the patients are asleep for the treatment because of the anesthesia, have no memory of it. The total treatment time, essentially, as it's done today, is approximately 15 minutes. So it's pretty, short time involvement as far as the treatment, and that's inclusive of the anesthesia, administration of the treatment. Typically takes about 15 minutes, though we like to kind of monitor them for 45 minutes or so afterwards, just to kind of monitor for that they're coming out of anesthesia okay, that they're not having any issues with that. And informed consent is typically obtained prior to the administration of the treatment, though there are some more kind of severe instances where it can be sought out involuntarily with a court order, but 99% of the time it's done with informed consent voluntarily. So indications for ECT, what is it used for in the modern day with the advent of medications? We have many different medications that are helpful today, that are kind of typically used initially before consideration of ECT. So when or in what application do we use it today? Well, it's used for depression. It's used to treat depression, both unipolar and bipolar depression. It can mitigate those symptoms. This is typically considered when people are refractory to oral medications. If they've tried several medications and haven't experienced any kind of improvement with respect to their depressive symptoms, oftentimes ECT is considered. It can be used for also mania in the context of bipolar disorder, as well as mixed episodes of mania as well. Once again, in the context of bipolar. It can be used for psychosis. Psychosis arising from, in the context of schizophrenia or schizoaffective disorder. Catatonia is something that it's shown to be very helpful for if someone has a significant depression that they're kind of rendered catatonic. ECT has been shown to be very helpful in terms of reversing the catatonia. It's also used less frequently for movement disorders such as Parkinson's, as it's shown to kind of improve Parkinsonian symptoms, though this is a less commonly used indication. So this kind of touches on, when ECT would be considered, in the context of a major depressive disorder, for individuals that, are severely depressed, that have not responded to trials of medications, it would be an indication. But also, looking in as far as the time of response, if someone is very severely depressed and there's concerns, it could be life-threatening. For instance, a very severe catatonia, if someone's not, eating or drinking, it may be indicated, or if they're acutely suicidal. Some common adverse effects associated with the treatment. There can be prolonged seizures. They can have respiratory or airway problems in the context of the anesthesia. They can have prolonged apnea. Sometimes there can be vascular abnormalities. Sometimes after the anesthesia, sometimes there can be some agitation, cognitive deficits. Those are all rare. And then the most common that I've seen are right after the treatment, headache, which is very common, muscle soreness, and nausea. So sometimes medicines are administered prophylactically for pain and things like that to prevent those side effects. This slide basically kind of goes into some studies that were done with respect to the mortality of ECT. You know, how safe is it? Well, in terms of the research they did, they determined that it's a very safe procedure. That the safety profile of the ECT may be better than that of some antidepressants. And they did a kind of retrospective review of patients and determined that they had some individuals with cardiac arrhythmias. None of the complications caused permanent injury or death. So overall, it's a safe procedure. And there's really no absolute contraindications for the administration of ECT. So it can be performed in various ages, even in older individuals. Sometimes in that context, once again, kind of speaking in terms of the context of medications, if people are unable to tolerate medications because of side effects and things like that, ECT sometimes is considered to be an option. Even pregnancy is not an absolute contraindication. Probably the only absolute contraindication would be like a mass occupying, like a tumor of the brain or spinal cord, because essentially in that case, there's concern that it would increase intracranial pressure with administration of the treatment. So the concern in terms of getting the treatment that most people share in terms of consideration of getting the treatment is the concern with respect to how it affects memory, how it affects cognition. So they've done a lot of studies in trying to determine, what influences cognitive side effects in terms of the treatment, what factors are involved. And because in terms of administration of the treatment, we want to minimize any and all types of side effects, especially memory and cognitive side effects. So this can kind of gets into the variables that can be changed to mitigate side effects and or consideration in terms of efficacy of the administered treatment. So these would be things like the waveform, once again, the dosing in terms of how strong of a dose is being administered, the number of the treatments being administered, how frequently they're being administered, such things as oxygenation, and also the type of anesthesia being used and medications. And this kind of goes back to the what I touched on earlier, which is kind of the pulse width and things like that, where it's in more favor these days to kind of use a very narrow pulse width, usually 0.3 to 0.5 milliseconds, as opposed to a longer pulse width, because they've discovered that using that minimizes the types of cognitive side effects. I think another important point is also the electrode placement. So we would typically start out, if someone were to come and be getting ECT initially, we would start out using it on one side, so using a right unilateral placement, once again, to minimize any types of side effects, minimize any type of cognitive effects. And this can be later changed to bilateral if need be, if it's felt that the patient isn't improving enough. So these are some data in terms of some studies that were done in terms of cognition in the context of ECT. What they discovered was that in terms of memory performance and reaction times, that cognitive function basically returns to baseline levels within 6 months. The sine wave, which is the older modality of ECT, had lasting effects, which is why, once again, concern for the side effects, that it's no longer used, and we're using primarily the brief pulse administration. Electrode placement can have an influence in terms of the length of cognitive effects. Also increased age, female sex, and a more impaired baseline performance at the start of treatment increases the degree of potential cognitive impairment with the treatment. Typically, for most individuals, the cognition that's affected in terms of memory are the immediate time surrounding the treatment, and can sometimes extend a little bit outside of that if people are getting frequent treatments, for instance, 3 times a week treatments. Bilaterally, they may not remember details surrounding the treatment, but typically once the initial course of the treatment is completed, there are no lasting cognitive issues.
So I have a lot of questions for you. So they keep popping up, and I was actually emailed a couple of questions. I was just wondering how is it all right to break in, or do you want me to wait?
Yeah, you can break in now.
All right, perfect. So I have a lot of questions. So typically, how long do positive results last?
Positive results are time limited. So in terms of expectation with the treatment, the standard kind of duration in terms of how long they last is 6 months. So it's not the initial course is not a permanent treatment as far as permanence in terms of how long it lasts. And in fact, after the initial course of treatment, which I kind of get into a little bit later, you know, there can be consideration of maintenance treatments, which are essentially treatments that are administered in kind of set periods of time, which varies from person to person, depending upon recurrence of symptoms. But in terms of having the initial course, it's about a 6 month window in terms of how long the treatment lasts. In terms of how I would typically practice, I wouldn't directly cut off going from an initial course of treatment to then no treatments. Usually I would kind of taper off and then get to a point that, you know, sometimes people come in once a month for a treatment, sometimes once every 3 months. Maintenance treatments aren't absolutely indicated for everyone. So I think it's looked at on a case-by-case basis in terms of recurrence of symptoms. If they do recur, there may be an indication to, you know, for those individuals that, you know, have responded well to the treatment that have a relapse in symptoms, you know, consideration of, you know, of maintenance treatments. There's also the role, you know, in terms of medications. Typically when people are getting ECT, they're also on some type of pharmacotherapy as well. And there is a role, you know, even if it's felt that, you know, medications have had a limited response, you know, medications in the context of ECT can also protect against relapse or recurrence of symptoms as well.
All right, thank you so much. So we only have about 10 minutes left, so I'm going to try to get to every question. There's a lot of fascination in this topic. So maybe too, if I don't get to the questions, I have them all written down. I could send you an email after to make sure, and then we can send the answers to some of the PAN committee.
Definitely.
How many slides do you have left? I just want to make sure that.
Well, yeah, this is actually what I just touched on. So the typical course. So yeah, an initial course is typically anywhere between 12 to 14 treatments, and that's typically done 2 to 3 times a week. That's considered the kind of acute treatment phase, after which, as we touched on, it's tapered down and discontinued, or done in terms of a maintenance at a variable determination.
You mentioned people with bipolar disorder earlier on in the slides, and I had a question: has it been used in persons with bipolar who also have an addiction to alcohol and other substances?
It has. The typical recommendation, if someone is presenting either, you know, with bipolar or major depression, and there's a co-occurring issue with substance abuse or alcohol dependence, the usual recommendation is that they get off the substance prior to consideration of the ECT, because alcohol and the substances can intensify the depression. They can kind of further kind of protract the depressive episode. And it also limits the efficacy of the ECT. So it's generally recommended that if someone has, co-occurring substance abuse issues, that they be that be essentially in remission for 3 to 6 months prior to consideration for ECT.
Okay. Has this been used in patients, or do you recommend it in patients with any sort of traumatic brain injury?
Yeah, in the context of traumatic brain injury, it can be used. That's not a contraindication, for its use. That wouldn't prevent someone, if someone were having depression or, some types of mood disturbances in the context of traumatic brain injury. It could be a good indication for that. It wouldn't prevent that individual from getting the treatment. Kind of edging into the realm of behavioral disturbances and things like that in the context of traumatic brain injury, or dementia or autism and things like that. That's kind of edging more into the realm of more kind of off-label use for ECT, though I've seen it used in that context in the past for individuals with autism, with very severe agitation and difficulty managing those types of behaviors with medication. Have received ECT, with benefit, but that's kind of going into a more uncommon usage.
Got it. So I'm glad you brought up dementia. A lot of us here, we're the Professional Aging Network, so most of us work with seniors. So are there enough studies to measure the efficacy in senior citizens for ECT?
Yeah, they have done various studies kind of focusing on different age ranges. People that are older that would receive ECT, they can be more, the sensitivity to the treatment can be more so. The sensitivity to anesthesia can be more so, can be more intensified than if people are younger. But the efficacy is there. So an elderly individual, versus a young individual, experiencing a severe major depressive episode, and if they're unable to take medications because of side effects, or the medications are not working, they would be good candidates to receive the treatment. Additional consideration, I think, would be, in terms of the treatment administration, would be geared towards minimizing, any memory issues. So I think approaching it from, the right unilateral placement, and maybe decreasing the frequency of treatments to kind of minimize those unwanted effects would be warranted. But it is efficacious in older individuals, as well as young. As far as the the contraindications, there, aside from the occupying lesion, there, people can get it done. You know, even people with pacemakers, I've seen get it done where they shield. You know, there's this kind of device that they put over the pacemaker which shields it. You know, and they can get it safely.
Thank you. So you mentioned, I have another question. You mentioned some of the pre-qualifications like diagnoses that are applicable for ECT. Are there any other medical pre-qualifications for seniors who opt for the treatment that we should be aware of?
Yeah, I mean, there's usually when individuals are considering, you know, the course of treatment, we'll have them kind of get some routine lab work. We'll have them get an EKG, also a CAT scan of the head is warranted, as well as a chest X-ray and things like that. So there's kind of a battery of testing that's done to, you know, make sure that people are healthy enough to get the treatment. I think you know, issues as far as cardiac arrhythmias and things, you know, need to be considered once again as far as the administration of the treatment. But for the most part, if there are kind of underlying, you know, let's say AFib or some type of cardiac arrhythmia, you know, they're typically being treated or they're on some type of medication to have that controlled. So barring, you know, that it's uncontrolled, you know, it wouldn't necessarily preclude someone from actually receiving the treatment itself.
Okay, and another question a couple of people have asked me is it covered by insurance?
It is, yes.
Oh, good.
Yes.
And then the other one I had was, you mentioned all ages, but is it applicable for patients younger than 18, or is it not recommended for patients younger than 18?
Yeah, children, it's it would be kind of a more extreme consideration for those under 18. But you know, there have been children that have received it, but typically it would not be given to those under 18, barring, you know, very significant psychiatric symptoms.
Okay, thank you. So we only have about 5 minutes left. So I have another question, and then we can get to a couple more slides if that's okay.
Yeah, I'm almost done anyway.
All right. So I had Jeffrey ask, can you talk a little bit about the ECT versus TMS?
Yeah, sure. TMS, which stands for transcranial magnetic stimulation, is also another modality that's used for depression. It's another kind of brain stimulation modality, essentially. It's performed by using a magnet which induces, has an electrical current. So it's an electromagnet that is placed around the crown of the head. And its purpose is to, you know, stimulate the neocortex using an electromagnetic field, as opposed to ECT, which is, you know, a direct electrical current. They are both used for kind of, they have similar applications, you know, depression, refractory depression, typically. It's very well tolerated. Treatments for TMS also typically last, you know, probably about 10 minutes. typically done on an outpatient basis, do not require any anesthesia. People are conscious, throughout the procedure. They sit in, what looks like a dental chair, and they have the magnet, and they, sit under the magnet for 10 minutes. The frequency of treatments, they're doing one treatment a day. And initial course of treatment is usually around 20 treatments. Has also shown efficacy for depression. So, sometimes there's kind of a step down process in terms of refractory depression. Individuals that first try medications, several medications, they're not getting improvement in terms of symptoms. Then they can consider kind of neurostimulation methods. TMS has very few side effects, can be done on an outpatient basis, doesn't require anesthesia. So oftentimes people will then go to the TMS and will receive a course of that. Sometimes if, that's beneficial, people stick with that. If people do respond to TMS, it's the same consideration. Do people have, do they go in for maintenance treatments? Do they, stop treatment altogether? I've had people do both. I've had people get the course of TMS, have felt better, and they're maintained on medication from that point forward. I've had patients periodically, go in every 2 to 3 months to, have 5 to 7 TMS treatments to kind of maintain the effect of the treatment as well.
Thank you. All right, so we have just like 2 more minutes. So, and then we'll have to say a quick goodbye to everybody. But as you can see, this was definitely an interesting topic because I had a ton of questions even before the program. So I think we have a time for like just one more slide.
Yeah, I can go through quick. This is just an example of the EEG. This is when a treatment is performed. This is what's kind of provided as a printout. And this kind of shows a baseline measurement. And then we contrast that with one which shows seizure activity in the upper 2 lines, which then kind of decreases back to baseline. And that's how we monitor, the efficacy of the treatment. We're kind of monitoring the seizure duration. So this gets into some other kind of theories. I think the main point of this in terms of ECT, but also I think in terms of the brain in general, is that we still to this day have a limited understanding in terms of how things work. So in terms of how ECT works, we know that it works. We're not really too sure how it works. So there's various different types of theories kind of focusing on neuroplasticity, changes in functional connectivity, changes in neurotransmitter concentrations, that all kind of theorize, how it works, but we're still not completely sure.
Well, thank you so much. Well, we got to the questions already.
I just want to thank the whole. I'd also like to just thank everyone.
Joanne, sorry, I had to put you on mute because there was a lot of feedback on the mic. So I just want to say thank you guys so much for this topic. Obviously, there were a lot of questions, so there were definitely a lot of interest in it. So do you have anything else to add, Dr. Estock?
Oh yeah, we have a new brochure. Also, I mean, if there's any questions that come up, or you know, there's anything that you would like answered, you can just contact me by email, or you know, and I can help out.
Do you want to put your email in the chat box so that everybody has it?
Yeah, I can figure out how to do it.
All right, guys. Thank you guys so much. Again, we really appreciate your time today. I'm going to stop recording this and just we'll be able to make this available for everybody post meeting on our LinkedIn page.